Good afternoon, everybody. Welcome to SEVA VentRounds. Today is April 14, 2026. And the title for today is Double or Simple, Effort or Error. Let's start with our disclosures. There's no endorsement of any mode, ventilator, or manufacturer. Whatever we say, it's our opinion, and it does not represent the Cleveland Clinic. Your hosts are myself, Eduardo Mireles, and Rob Chatbur. And today we have one of our SEVA instructors, Karsten Roberts, who will be guiding us through the forest. In terms of ground rules, please keep your microphone muted. Karsten may call upon you to make comments if needed, but if not, just put it in the chat function. We're monitoring that. We take a look and then comment as we go through. However, if you want to make a comment, please do unmute yourself and let us know. There is CME and CRCE for respiratory therapists across the nation, and CME for those in Cleveland Clinic. And so let's just start really fast with this key SEVA knowledge before we dive into the image. And this is relevant because it will help you view this a little bit better. So in these three panels, on panel A, all the way on the top, you have a patient in which is breathing with essentially no pressure. So on CPAP, in green, you see that there is no pressure from the ventilator. And the flow is in black, and in red is the PMOS. And you can see the flow is sine wave, and the patient then exhales passively all the way out. In panel B, it's a patient that has no PMOS, so you can see that the red line is flat, but you can see the green line goes up. And so there's a step up in pressure. And with that step up in pressure, the flow increases rapidly. So there's the peak flow, and then it decays exponentially, governed by the time constant, until it reaches the end of the breath. And then the exhalation is passive and following a very similar trajectory as the inspiration. In this model, these are simulated waveforms. And then in the last one, on C, you have now both PMOS and PVent active. And so here you have PMOS going down, and then PVent in green going up. And yes, if you're a careful observer of this waveform, you would say that there's a delay on when the PMOS starts and when the breath starts. But of note is how the concavity, that exponential decay, that nice exponential decay that we had, got lost. And now it looks a little bit more straight than before. And in this case in particular, I want just to highlight to you that at the end of the breath, so the patient has stopped doing effort, and now it has relaxed. So you see the PMOS is essentially flat. There's no expiratory muscle activity. The patient has relaxed. And the flow goes beyond the baseline. So the patient is exhaling during inspiration. Now, some ventilators let you do that, and some ventilators don't let you do that. Some ventilators essentially close the valve and don't let you exhale during the inspiratory time if the flow tries to go negative. And this becomes evident here as you see the flow, the volume reach the top, and then it starts decaying, and it decayed below the peak. Rob, before we dive in the next case, do you want to comment a little bit about this behavior on ventilators, please?
Which portion of the behavior that you want to comment on?
The exhalation during inspiration and its effects.
Oh, well, on this particular ventilator, I think you're looking at a servo, simulated values of a servo. Some ventilators in pressure control modes let the patient freely inhale and exhale during the preset inspiratory time, and some do not. And for example, on a servo ventilator, the ventilator will not let the patient exhale unless the patient forcefully exhales and the pressure rises, I think it's 3 centimeters above the target value, and then the valve will open and the patient can exhale. But in between that time, the airway is occluded. Is that what you're talking about?
Yeah, and so during that period of time, the pressure that you get would be akin to the plateau pressure, correct?
Yeah.
Very good. So, and this just for setting up for the team. So I think the salient items is, remember, when PMOS, if there's no PMOS, there's this exponential decay. If there's PMOS, in this case, it lost the exponential decay, and then we're going to talk more about what happens if you try to exhale during inspiration. All right, Karsten, all yours. And
Oh,
this is a
good.
gift from Ariel Garnero, and just for the team. Ariel is one of our respiratory therapists, and Karsten Roberts is one. And Karsten, you can say what your title is, but it's a master educator at Jefferson System for Respiratory Therapy, and we're lucky to have him host with us today. So, Karsten, go ahead, please.
Yeah, thank you for having me. So I'm an assistant teaching professor at Thomas Jefferson University in Philadelphia, and I have been working with Rob and Eduardo for some time and gone through SEVA methods. So it's great to be doing this part now as the facilitation. So I'm just going to jump in and ask that you all participate and help me out. And we'll start with our SEVA methodology and what is the tag for this? Eduardo says we're not trying to hide anything. I think it's pretty obvious. Just throw in the chat and people start to already add their comment. So yeah, so pressure control, CMVA. Is there anybody that would disagree with that? Okay, great. So then we'll move on to the inspiratory load. We have elastic, resistive, or PMUS. And does anybody have an opinion about what the load is for the inspiratory portion of this breath? Okay, so everybody pretty universally it says PMUS. Great. And we can see that because we have this ventilator, which the waveform actually shows us where the patient is making an effort, and then we can also see as Eduardo is drawing on the flow waveform that we don't see the exponential decay as we would expect in each of the 4 breaths that are on the ventilator. So that's where we can tell for sure that the patient is making an effort through the inspiratory phase of the breath. And then what about the expiratory phase? I think that this is where this particular waveform gets a little bit tricky. And as Rob is pointing out in the chat, that the tag can be found in the ventilator mode map for this particular ventilator. So we have 1 vote for a resistive load. Does anybody see anything differently with the expiratory flow? So right now it looks like we're kind of between resistive and PMOS. And now elastic load joins the discussion. So I think that it's easy. Eduardo had already started to kind of label the breaths, and I think that that might help with us moving forward, is to look at each of the breaths in sequence. So we see 4 different breaths on this screen, and I wanted to call your attention first maybe to the first breath and the flow wave form in the first breath and the 4th breath. any opinion about how the expiratory, does that, if you said elastic or resistive or PMUS, do the two of those breaths change your opinion in any way?
And a trick here that may help you guys is to remember that sometimes the flow waveform doesn't show everything, or the scale is not as pretty as you want, and you always have the amplification that occurs in the volume waveform, and that may help you see a little beyond, or to characterize how is the decay during that period of time.
Yeah, so I'll get to Ari's comment about the expiratory volume in the second and third breath, but I think to Eduardo's point, it appears, despite the PMUS that we see in the inspiratory portion of this, that looks like it might start to go into the expiratory phase of the breath a little bit. It to me, this looks almost passive. Do you agree, Rob or Eduardo?
Yeah, I think so. I mean,
Yeah.
it's a very curious image. I think if you look at the markers for seconds, it takes a good amount. And you made this comment earlier today that it took a fair amount of time for the patient to get out and not to
Yeah.
get to the baseline, right?
Right.
And go ahead.
Yeah, so I mean, if you look, I tell my students this all the time. If you look at those hash marks down at the bottom of the screen, there's almost 4 seconds that go by. So I think it is a good indication to us that there's some sort of resistive load happening, because it takes so long for these breaths to come back to baseline. Now let's move on to the second and third breaths, and what's happening here in the second and third breaths. As Rob points out in the chat, that the normal time constant's about a half a second. Normal passive expiration should last about 1.5 seconds, because we expect it to be 3 time constants normally. So any longer than that, and we can say that we have a higher resistance. So yeah, this is definitely beyond that 1.5 seconds for the expiratory phase. So Ari pointed out a moment ago that the volume cuts off and that we see this chunk out of the expiratory phase of the breath in the flow waveform, where we don't see a flow for almost a full second, and then we kind of see the breath go back to what I would describe as almost normal, or expect, at least what we would expect from looking at that first expiratory cycle. And Sarah's pointing out, is the patient still trying to breathe out? And I think, is there anybody else that would share that opinion, that there's some sort of work being done during the expiratory phase of the breath? And I think it's a good question to ask, why is there some sort of inspiratory pause observed? And I think that both Ari and Sarah are on to the fact that this is that there is zero flow happening during that portion of the breath for a particular reason. Eduardo, I don't know if it's should we move with the patient ventilator discordances before we address that?
Yeah, so I think so. That's great, Karsten. The team has identified something that it's abnormal, right? They identified a lack of flow when the patient triggered two breaths, and you identify those two. So why don't we go into the discordance, and that may help us understand a little bit more this waveform, which is not a simple one, and you're doing excellent at dissecting it. So let's keep going.
Yeah, great job, everybody, and thank you for your input. So any patient ventilator discordance is occurring. We'll starting with the trigger. Do we see a normal, early, late, false, or failed triggers? Okay, perhaps a false trigger, maybe in the second or third breath. Anybody else? Normal, normal. Yeah, I like the idea of a normal trigger, because whether or not the patient makes an effort or the ventilator delivers a breath at a set time, I always ask what should happen in that moment. As soon as there's a trigger from any source, what should happen? The ventilator should pressurize, right? And so we see this pressurization of the ventilator as soon as there's a trigger from the patient. And so there's no delay in it necessarily. So I don't see that as a late, an early trigger or a late trigger. I think that, again, this is a complicated waveform. And so the idea that there's a false or a failed trigger occurring somewhere is tempting. But I will go with the consensus on the chat that says that this is a normal trigger.
Yeah, so sometimes it's easy to, I mean, there's so much cardiac oscillation and noise that I can see people thinking, I mean, you should have a high suspicion, Carson, right? That this could be a false trigger, but there's a marked amount of PMOS demonstrated in the trigger. I mean, it's a pressure trigger, and you can see how much it drops the pressure. So that makes me less likely to think that this is a false trigger. And there's PMOS throughout the breath. So I am completely with you that this is normal.
But there's two trigger events, right? There's two white
Yes.
lines.
Yeah,
Yes.
and we're definitely getting there. So really quickly, do we see any evidence of over or under assistance in any of these breaths? Angel says that it's normal, that we just see assistance. We don't see evidence of over assistance or under assistance. And I would tend to agree with that. So let's look at the cycling. Is this a normal cycle? Yeah, and very quickly, everybody chimes in to say that this is an early cycle. It's certainly not normal, as Rob pointed out, because we see this second waveform coming. And I think that it's the temptation, at least within the respiratory therapy community, to come into the room and see something like this and say, the patient's breath stacking. But not addressing the issue as to why. And so it's important to identify that this is an early cycle. And I think before we continue on with that line of thought, I think it's important to identify what's happening during the expiration also. So what's really happening? There was a couple of people in the chat that mentioned that the breath looks forceful, that the expiratory, Ari pointed out that the volume cuts off in the second and third breath. So what's really going on here, where we see really no flow during the first portion of the expiratory part of these two breaths. I guess I'll ask the question, what can cause this? Yeah, ACCM says that the patient inspiration against the ventilator exhalation. And Ryan asked the question, is the ventilator cycling off because the P-vent has exceeded the safety parameters set in PRVC? It's a good question. A patient is trying to inspire, and for the patient to produce a hold, the P-vent must equal P-must. I think that's a great comment, Ari. So we see the zero flow state, and typically we're only going to see that if we do an inspiratory breath hold on the ventilator while we sit at the bedside and we're trying to get a plateau pressure. We can talk a little bit more about that, but I think it's also why is the patient still doing that effort that we see here, where where it's like a forced there's some sort of forced expiratory work being done to cause this zero flow state against the ventilator. How do we fix that? So we have an early cycle, and maybe taking that part of the conversation into consideration will help you decide how you would fix this in a clinical. I have an early cycle. How do I allow for that to be fixed? By increasing the eye time, right, Arsal? So we would increase the eye time to fix about it. So we think about this expiratory work that's happening to cause this zero flow state. Is there anything that we should add, Eduardo?
Yeah, I think first, just in case, if you are not muted, please mute yourself, just so that we don't get the background noise. But the thought process here is great. So you have a patient trigger breath, all right, and then the PMOS continued and triggered another breath. So that's why we're saying that this double trigger or multiple trigger is due to an early cycle. So the early cycle caused that double. And the odd thing is that in usual behavior, Karsten, you would expect flow to occur here, right? So you would expect the air to go inside the patient, and instead of that, we're not seeing any air going in. And so you mentioned PMOS as being one of the causes, and can you just clarify, when you say PMOS, you refer that this patient is exhaling, inhaling? What do you refer by PMOS here?
Yeah, so I mean, I think that this goes back to the simulations that you showed at the beginning, of where we see that the patient could actually continue to take a breath through the beginning of the expiratory cycle. So is the patient continuing to, like, they started, I guess the question is, where did the breath end? Where did the patient's effort end?
Yeah. So great point, because I think that there's two items here to highlight. So if the patient is doing PMOS during this part, during the area that is red, you would expect the flow, and when I say PMOS, I mean inspiratory PMOS, you would expect the flow to go above that, right? And you're not seeing that. The patient is not getting more air in. Instead of that, it's getting none. And so this could be that the patient is actually bearing down. And we have seen that on patients with severe obstruction, that they have activated expiratory muscles. So the muscles are active, the ventilator pressurizes, and it doesn't have enough pressure to overcome the expiratory PMOS. So this can certainly be a manifestation of expiratory PMOS. But you made a case that there's actually it's not very clear to us that there is expiratory PMOS on these periods here on breath number 4 and number 1. So that makes you think, well, is this patient really bearing down to exhale? And it's not very evident. It could be happening, and only Ari has that answer because he was at the bedside. But if the patient is not bearing down, then what's the other alternative? And the other alternative is that you're talking about the PMOS that occurred back here. And that's an important thing for us to think. So if the patient is doing expiratory PMOS, there will be no flow during this period of time. But if the patient did PMOS beforehand, right? And so if you think about this, the patient is putting air in above of what the P vent would have placed. So the ventilator was pressurizing, and PMOS and P vent were active at the same time. And then the breath ends, and now you have, because this ventilator doesn't let you exhale during inspiration, as you can see here, there's no air coming out. Now you have here a respiratory holdout, so a plateau pressure. Does that make sense, Karsten?
Yeah, no, it definitely makes sense. And, as we're talking about it, I was thinking that this could potentially be a patient with COPD, like you said, that's bearing down, it's hyperinflated lungs, and maybe has this high, maybe this almost a resistance towards the breath going in, because the pressure, as somebody had pointed out, that the P vent and the P must equal at some point. There's this pressure gradient that somehow meets equally in the airway and the pressure of the alveoli, and makes that stops that to flow. But you're pointing out, or the different ventilators have different ways of reacting to this, right? So this particular ventilator doesn't allow you to take a breath in. So we have the zero flow state during that first part of expiration. So I think that makes complete sense. And I think it's important to point out, if we were doing a breath hold ourselves, what would the expected outcome be? What would we see potentially on one of these other, either breath 1 or breath 4, if I did an inspiratory hold on a pressure controlled mode of ventilation? What would the outcome be?
So either it goes up, it stays the
Yeah.
same, or it goes down.
Yeah, so there's 3 options, right? And I think if I was to superimpose options A, B, and C onto breaths 2 and 4, we clearly see that the pressure has gone up. And so this is really, with a zero flow state, this really is a plateau pressure, as compared to the breaths that are mandatory from the ventilator.
Very good. Rob, any comments here?
Rob, I think you might be on mute.
Sorry
Or
about
if he's
that.
there you go.
Look on breath 3 on the flow waveform where Eduardo has drawn a vertical line and a little arrow. You see that noise where the flow oscillates through 0? One idea might be is that the patient gets a breath, the ventilator then cycles off and experiences that noise and auto triggers, and the patient doesn't like that, so he bears down immediately, and that's why the flow goes to 0.
Yeah, interesting. I like that idea. I think that in order to determine if that were true, we would need to know if this is cardiac oscillations, as Eduardo pointed out, mentioned earlier, or was this, you know, fluid in the circuit that's causing this noise? I think that that certainly could also cause a false trigger, as you mentioned, Rob. So I'm not like I think that, but also I think Eduardo points out that the argument against maybe a false trigger is the amount of work that this patient is doing in order to trigger that breath. So I don't know if I don't know if I buy that, but I'm open to changing my
Yeah.
mind.
Well, this but I think that the key item, I love this discussion because you're outlining the two causes, two of the key causes that could be pointed out here. One is this a early cycle as a cause of the double trigger, or the other one is a false trigger causing this extra breath there. Regardless, the manifestation is going to be very similar. It's in a patient in which you had PMOS and then no more air goes in, and it's either because of activation of PMOS before as inspiratory PMOS or PMOS after as an expiratory PMOS. All positive statements, which so how would we solve this at the bedside? How would this help us understand it? And if you start thinking through this, just for the sake of time, is one, you could change the trigger threshold to try to make it harder and see if that highlights if this is PMOS or is it truly an artifact that may give you some answer to that. There's you could also do an expiratory hold and see the length of your inspiratory time. That's something else that can help you see through this. But being at the bedside and having a waveform in which you can modify those things can help you understand a little bit better which one are those.
Yeah, and I think it's interesting that as you're talking about doing an expiratory pause to measure the amount of PMOS, Ari is pointing out in the chat that in particularly in breath number 4, where we see a very convex portion of the flow deceleration. It's more so than the previous breaths, and we actually don't see that that pause. We don't see that second breath, and
Yeah.
that's I think that that's really interesting that that fourth breath doesn't actually trigger an double another breath, or it doesn't stack that breath.
Yeah, I agree with that. I mean, when I was looking at this the first time, Ari, is that I was looking at this straight line. I mean, because I would expect that to look like that, like this one, but very rapid decay, boom, and it comes out. This one, you see how it's not as perfect as it should, and it could be noise from the cardiac oscillations, but it could be also PMOS. This is where an EDI, an electrical activity of the diaphragm, or esophageal catheter really helps clean out what actually is happening in these patients. Not that you need to put it for this. Usually, this just requires some changes on the eye time and changing perhaps the type of mode if it's feasible, depending on the goal for this patient. But that would be kind of the gold standard when you see something beyond the waves on its own.
Yeah, so just to summarize, increasing the eye time or switching modes could potentially solve this.
Mhm.
Also, it's interesting that the volume cuts off, right? And I think it's just because we have that
Mhm.
zero flow state. The patient is bearing down, or like so the volume is just not going in anymore, which is why it goes so suddenly to zero.
Yeah. Yeah, so what does, it resets. Remember that the volume resets to zero when another breath is triggered. So this breath was triggered, and this patient did not exhale, but this amount. So the patient exhaled from here to here, very little, and in this one from here to here, very little, and it got reset to zero So it looks like the patient exhaled a lot, but it didn't. It's all inside this human, but the count reset to 0. So, and then no volume went in. So that's why it looks like this. All right. Just go ahead.
Oh, I was gonna say in the interest of time, we gonna show another waveform that we've seen before. Did you want to review this?
No, go for it.
Okay. Yeah, so so this is one that we've looked at before, and we see essentially the same thing with this inspiratory work, the PMOS that is present through this breath. And if we actually drew out what we would expect to see here, we see this kind of like what Ari pointed out, this very convex pattern that's that we don't see the flow decay as we think we should. And then if we look at the pressure waveform and we square that off the way that we would expect it to, it accounts for the work of breathing that is that is happening in this particular patient. And we see the same thing happening where this plateau, we have a plateau at the end of the breath.
Yeah, that's a great point. So this is out there in the literature now. I mean, this one is intentional because we set the I time too long. And in this ventilator, it causes a pause. Now, that doesn't happen on all ventilators. Let's be clear. It happens on this one. But you can see that the patient was doing PMOS. So PMOS on top of P-vent gives you a higher plateau because more air went into the system. And then you close the system, it relaxes. You don't see any effort in this patient. And that's called the pressure muscle index. And it's a marker of PMOS during inspiration. Marker of PMOS during inspiration in a pressure control mode. Excellent. So why don't you round us with some takeaway home messages for everybody, Karsten?
Yeah, great. So I wanted to focus primarily, I think that when we do this education, the question that we often get at the end is, how do I fix it? So I think highlighting the 2 key points of increasing the I time for someone that has an early cycle, or simply switching to pressure control CSVA to potentially help with the patient's comfort and interaction with the ventilator, aside from being on PRVC. And then again, we remembering that if we're in a pressure control mode of ventilation and we do an end inspiratory hold, that you can have a higher pressure reflected in that breath hold, or you can have the same pressure, or you can have a lower pressure, but it is certainly possible to have a higher pressure, particularly when we have active PMOS from the patient.
Excellent. Rob?
Just to add that these concepts that Carsten just pointed out, they're covered in the online SEVA basic module.
Excellent. So yeah, this is a common, I think it's a myth. I love that you brought that up, Karsten, is that you can have a plateau in PC. If it's higher PMOS, if it's equal, that means that you reach 0 flow during the inspiratory time, and it's going to be the same as the inspiratory pressure. And it can be lower if the flow is not 0 at the end of inspiration. And that's a very common item to see. All right. With all of that, first of all, Karsten, great job. This was a very challenging waveform, and there's a lot to extract from it, without a doubt. For the sake of time, I think that we did wonders on talking about it. Second, I invite you to claim your CMEs and CRCEs. This makes you more powerful and demonstrate that you're getting and want to improve. And then inviting you to see the prior episodes and register for our SEVA courses, and then obviously send us your waveforms. The more waveforms we get, the more we learn. Have no fear. Karsten, you want to say a goodbye message to anybody?
Goodbye.
All righty. Have a great one, everybody.
Thank you.